Hi, thank you for coming. My topic is testing for anti-microbial antibody with cross-reactivity to human tissue in autoimmune disease by myself, Larry Minardi, Todd Kunstner, Steve Zakon from PZM Diagnostic, Charleston, West Virginia. Financial disclosure. All authors, stakeholders of a PZM Diagnostic, a private company registered in the state of West Virginia, USA. PZM Diagnostics was set up with one goal and one goal only, that is to culture mycobacterium from blood of Crohn's disease and subsequently Sjogren's. This particular mycobacterium is Mycobacterium paratuberculosis, also known as a MAP. We use three separate independent methodology: blood culture, molecular identification of MAP from the blood, and the serology testing for anti-MAP antibody. After 18 months and a few hundred patients testing, this is the data we have. First, there are many bacteria we see in the blood, and that can be cultured by different media, but not by the automated blood culture instrument in the hospital setting. Second, and there are many bacterial DNA we see in the blood that can be identified by PCR using 16S rDNA primers and metagenomic sequencing. And this has been validated by many different laboratories in the country and throughout the globe. The third, there are a large number of patients, greater than 70 to 80% of patients carry an antibacterial antibody, and the antibacterial antibody are very specific. This is a very much counterintuitive and polar opposite to the viral immunity, where antibody is protective, but in this case, antibody is pathogenic. Once we see the antibacterial antibody are significantly higher in patient, we want to know if these antibodies are specific to specific bacterial proteins. So to do such, we did Western blot analysis. Western blot is very similar to Lyme Western or HIV Western blot. You run the bacterial extract on the gel and blot it onto the membrane and incubate the membrane with a serum or plasma from the patient. As you can see, A, B, C are three separate patients, and you see there are very specific interaction between the patient's blood serum and the specific protein from the bacteria. Different bacteria react differently to the patient's blood serum, and you can see there are multiple different bands with the specificity. Once we know there's a specific interaction between the patient's serum and a specific bacterial protein, we quickly identified these proteins. All the band from the previous Western blot has been identified through immunoprecipitation and mass spectrometry, and you have a list of protein from the bacteria, from different bacteria. Once we have the name of these bacteria, we can do different experiments. Next, the first thing we did, we purchased the commercial antibodies against specific bacterial proteins, and these are the antibodies commercially available, raised in the bunny rabbit or mice to specifically interact with the bacterial protein, and we incubate these antibodies with human tissue on the slide. As you can see, there's a very specific interaction between the antibacterial antibody to human tissue in a very specific cellular compartment, and indicating the antibacterial antibody can react to human tissue. The next thing we did is we did a sandwich ELISA assay. We coat plate with antibacterial antibody and add bacterial extract on top to it, and the bacterial protein captured by the specific antibacterial antibody. Then we lay down the patient's serum or plasma on top of it, and if there's a specific interaction between the bacterial protein captured by the antibacterial antibody with a human serum, we can detect that. As you can see, in Crohn's patient, which is shown blue, the control showing red, and there's a significantly high antibacterial antibody titer within the patient, but not in the control. As you can see, the specificity is up to 81%, sensitivity to 70%. The next thing we did is we took 288 blood donor from the Red Cross, and we did a seroprevalence test and see how prevalent of this antibacterial antibody within the normal blood donors. As you can see, the 6 antibacterial antibody range from 1% to 4.56%, whereas the patient is significantly higher. The p-value is less than 0.001, highly statistically significant. At this point, we can say their antibacterial antibody is very common in Crohn's patient and the Sjogren's patients, and we also tested RA patient, lupus patient, MS patient, and we test some of the Alzheimer patients also. The antibacterial antibody can cross-react to specific human tissue. And we came up with a panel. It's called a PZM panel, and 6 bacterial proteins to detect 6 antibacterial antibody, 3 from Staphylococcus family, 1 from Mycobacterium family, 2 from E. coli family. The Staph aureus and the Staph pseudointermedius is fairly common. The Staph pseudointermedius is a commensal bacteria from domestic dog. To the dog, the bacteria is not pathogenic, but this particular bacteria can cause human disease. HSP65 is from Mycobacterium. It's very common. There are many autoantibody against HSP60 in human, which is equivalent to HSP65 in Mycobacterium. And this autoantibody has been reported in many diseases: autoimmune disease, cancer, and Lyme disease. P58 on the Lyme Western is basically the same protein as Mycobacterium HSP65. The EF2 from E. coli, autoantigen EF2 has been reported in patients with Felty syndrome, rheumatoid arthritis with neutropenia. Next thing we did is that we took all the human autoantigens, autoantigens. We examined the autoantigen amino acid sequences using BLAST-P computer program against the bacterial database, fungal database. As you can see, BLAST-P, you examine the homology between the human protein and the bacterial protein. The output from BLAST-P program, you can see homology low, homology medium, homology high. They are color coded. Red indicate high, pink indicate medium, blue, green, and black indicate low homology. And we examine all the autoantigens, and this is what we found. Totally, we did a 64 autoantigen examined by BLAST-P. 26 show high homology, 19 medium homology to bacterial proteins. 27 high homology, 16 medium homology to fungal proteins. Noticeably, we didn't do the viral protein homology because viral antibody is protective, is opposite from the bacterial immunity. There's some surprises. Specific bacteria and fungi causing specific diseases, and there are specific antigen from specific microbes. For example, anti-Smith antibody in lupus, anti-U5 antibody. U5 autoantigen is very specific to Candida albicans. Another example is a human proinsulin. Human proinsulin amino acid sequence is highly homologous to Enterococcus faecium and Enterococcus faecium only. That's pretty interesting. And most of the autoantigens are enzymes, and for example, ANCA antibody, myeloperoxidase and proteinase, abundantly present in the bacteria or fungi. So we had a paper, is available on bioRxiv, if anyone can see it. I wrote a book and summarized all the analysis in here and more, including some genetic knockout mice and human disease and such. And the book is coming out in a couple of weeks. In summary, most of the autoantibodies, close to 2/3, are likely against bacteria. And in order to keep the antibody level high, you have to keep a stimuli constant. Otherwise, the antibody level will fade. We can say that the antibacterial antibody can cross-react to human tissue through molecular mimicry, and the molecular mimicry concept has been around for 50 years. So testing the antibacterial antibody can be a diagnostic for autoimmune disease. Antibiotics to eliminate bacteria likely benefit some of the patients, some of the autoimmune patients. I'm not here to advocate using antibiotics randomly because across the hall there are guys talking about antibiotics abuse and antibiotics resistance and such. But certainly discretion is needed. That's all. Thank you.